Sharon Uchi. Health is often described as wealth, and one of the greatest challenges to public health around the world remains tuberculosis, commonly known as TB. Despite being preventable and treatable, tuberculosis continues to affect millions of people globally, causing illness, loss of productivity, and in some cases, death. Many people still lack adequate information about how the disease spreads, its symptoms, available treatment options, and the role communities can play in preventing it. On this program, we break down medical issues, speak with experts, and provide practical guidance to help you live healthier, longer, and better. This is Health Matters, where your health comes first. We'll take a short break now. Stay with us.
Every second, the world changes, markets rise, leaders speak, stories unfold. To keep up, you don't just need news, you need clarity, you need speed, you need perspective.
That's why Aneke TV brings you the global pulse. Accurate, reliable, right when it matters most. Aneke TV. Move with the world.
Welcome back. Today on Health Matters, we are discussing an important public health issue, eradicating tuberculosis. Tuberculosis remains a major concern, particularly in developing countries, where awareness, early diagnosis, treatment adherence, and community support continue to play vital roles in controlling the disease. As efforts to eliminate tuberculosis continue, organizations, healthcare providers, community groups, and development partners are increasingly working together to strengthen healthcare services and ensure that affected individuals receive the care they need. One of such efforts is the community-led monitoring project currently being implemented in Enugu State, which seeks to strengthen accountability, encourage community participation, and improve access to quality TB and other healthcare services. Our focus today is eradicating tuberculosis, the role of communities and healthcare stakeholders. Joining us in the studio is Chief Uchendo Godwin Agudioka. Pardon me if I didn't get that correctly.
That's Agudioka, yes.
Okay. State Coordinator of the TB Network Nigeria Enugu State Chapter.
Thank you very much. That's
Welcome,
right.
sir.
Thank you very much.
We are glad to have you in the studio this evening.
Yeah.
Okay, let's begin our discussion. Despite years of intervention and increased awareness, tuberculosis remains one of the leading public health concerns in Nigeria. As the state coordinator of the TB Network Nigeria Enugu State Chapter, from your perspective, what are the major factors that continue to drive the burden of TB in our communities?
We have to underline the challenges first, because the challenges still remain upon the government efforts. The challenges still remain social stigma, where people are, apart from ignorance, people are hiding because of the social stigma that is attached to the disease. Once earlier detection is made, treatment is just free and in a short period. So the problem now we have, why I started with the word challenges, is because upon all the efforts, people don't want to avail themselves to the services rendered by the monitoring team.
Yeah.
You see, there are other factors fighting community mobilization, the fight against tuberculosis. But the main factors is that ignorance is still one of the problems. People don't want to listen. People don't want to get themselves to avail to the services rendered. Again, because of that, some of the drugs already supplied free of charge by the government and the development funders are expiring from time to time in the facilities because they are not, nobody is assessing that. But with the media and what we are planning to do with community-led monitoring, that is the only way out, because when we go to the community, we look at the gatekeepers, we get into them and tell them the need of going to the hospital, health facilities to access the drugs, and at the same time, stop taking treatment unless if it is diagnosed. One other problem is that you cannot treat what you don't know about. Somebody may have headache. Evelyn may have headache. Thompson may have headache. You give PCM paracetamol, because somebody is having headache. You don't know the reason why Evelyn is having headache or the other person is having. So the most important thing is to go to a lab, find out exactly what is wrong. Some cough is not even TB. Just like as we talk about malaria. Malaria, all the fever is not malaria. It is only when it is diagnosed, tested, then you now know what to start doing and when to start doing that.
Okay, so let us just wind back a little. Now, talking about malaria, is there a connection between malaria and tuberculosis?
Because of what the international organization is doing, the funders, and Nigeria at large, we have something we call ATM, not the one of the bank. ATM, AIDS, tuberculosis, and malaria. And you cannot do this one and leave the other one. Like in Enugu, they call me Mr. T, because I'm in charge of tuberculosis. They call Florence M, because he's in charge of the other side of immunity, nutrition and so on.
Okay.
Then the other one, HIV, before you talk about AIDS. You know, when it is HIV, it is even manageable. But when it becomes AIDS, it is only Jesus that will know what is going to happen.
You know, we started on the factors when I asked you what are the factors.
Yeah.
And you went back to the challenges. So can we speak on that?
Yeah, we can go back to it, because
yes.
I was telling you, you are thanking government and the people because they are trying their best, but it is not yielding a fruitful result as required. Okay. Then I have to tell you that it's because of the challenges we have. When you don't come out to tell a doctor or a paramedic that you are sick, you are coughing for more than 2 weeks, how are you going to now start doing anything? So the media should help us to make sure that people who have cough for more than 2 weeks should come to the nearest, go to the nearest health facility, whether it is owned by government, whether it's owned by individual.
Okay. Okay. Beyond the medical aspect of the disease, I believe there are some social and economic factors that come into play. Can you mention some social and economic factors that come into play when it comes to the disease?
The disease, if I should understand where you are coming from.
Yeah.
Social aspect of it.
Yeah, like the society.
The society.
How do they
There are people up to now, apart from what media is going to help us to do.
Okay.
People are still believing that it is witchcraft. There's nothing that can infect anybody about AFB, acid fast bacilli. That's what we call acid fast bacilli. The animal inside the body that you cannot see without microscopic, even some microscopic this thing cannot see. We use what we call gene experts. That is where you see the particular microorganism that causes the TB. And it cannot affect anybody except from the nose. If anybody have toilets from here to the other municipal council, you can be here and you magnate it because of your ear. So that is why we advise people not to cough anyhow in the public, even in the church, even in the house. And they should live in a place where there is ventilated distance. People should not be there 8 or 9 or 2 or 3 in one bed, in one room. It's not good, because if the person coughs and the bacteria goes out, you sneeze it, and if you sneeze it, it goes to the lung. Some may not even be discovered unless you use the accurate material to do that.
Okay.
Then another one, husband may not allow their wives to go to access these medical services, because they will tell them, my friend, why are you going to that place? It is because of maybe I and the Okeke was quarreling for a land that they use what they call witch, and they don't want to believe that this thing is airborne disease. Airborne disease. I repeat it, it is airborne disease. Nothing can affect anybody about that except if the person sneezes, there's something from through the nose. Am I answering your question?
Yes, of course.
So that's one of it. Then another one. When I was managing with my first hospital, Abakaliki, some people will leave IDH here in Enugu, go to my first hospital, Abakaliki, because they are hidden. They don't want even people to know that it has CP. How can you now manage this thing? Some people will go there and change their names at the card in, card out. If you come to look for somebody, they say that they don't have such thing. So those things are part of the things that we should fight against, so that people will now realize that it is better you say, if you see something, you say something. That is the language.
Okay, and let's talk about the poverty aspect. We often hear that tuberculosis is closely linked to poverty. How do poor living conditions and limited access to healthcare affect?
It's one of the biggest problems. Like, if you don't eat real nutritious food, you can't even sustain taking the drug. First of all, if you cannot eat 3 good square meals, you will abscond from taking treatment. And the law says that if you abscond from taking treatment, after 8 months or something like that, the thing will come back again with a big blow. Because that time we will place the person in what we call DRTB. DRTB means drug-resistant tuberculosis. There is another one called DS. That one is you can be placed on treatment and you make sure you follow the treatment. You don't default, adhere strictly to the treatment. You will be okay within 6 months. But if you have 2 diseases at a time, the microorganism that causes TB and you have HIV, we abandon giving you treatment for TB. We face HIV because we will try to make sure that your immunity comes up so that you can now sustain the drug that is going to give to you. After treating the HIV something, then put it to management level, then we'll commence giving you the treatment for TB.
You know, when I talk about poverty, it's the poor standard of living, not being able to access healthcare.
That is one of it. Even somebody who cannot even have 1 square meter, 100, may not even have transport. Another problem is that the places where this drug is assessed may be far from the patient. He cannot have even money to eat, talk less of asking him or her to go to that clinic. So that's one of the poverty problems. Okay. You understand? Yeah. So this is why now the community-led monitoring goes nearer to the doorstep of the patient, talk to him or her through the gatekeepers. Why? We don't want him or her to start thinking about going to UNTH because of transportation. And by the time we bring that into the doorstep of that particular person, what will now stop him or her to start taking drugs? So that is one of the things. So poverty is one of the problems faced by the victim, by the people who are infected with this thing. That is why when I established what I call a Society of Persons Affected by Tuberculosis, people don't know what I was talking about until it was registered in Geneva. And as soon as it's registered in Geneva, that's what SOPAT is all about, Society of Persons Affected by Tuberculosis. If you are not directly infected, you are directly or indirectly affected. What does it mean? If a patient is having this contagious disease and is not treated, the whole people in the family is in danger. The whole people in the car is in danger. The whole people in the church, left and right, are in danger. So if you have a patient or you have a relation that have TB, then you are affected. So that is the first thing I established 14 years ago. And for that 14 years ago now, led us to get what we now call Godwin Super Development Initiative, also registered with Switzerland WHO. Then it is now the Godwin Super Development Initiative that is housing the TB Network Nigeria, Enugu State Chapter. And so that is exactly the thing. So we didn't just climb up stairs without matching the carpet. So that is why WHO, IHVN see that the only thing to make this thing stand well in Enugu is to ask myself, who have just told you my name, to go and canvass and see if I can campaign to be what? The state, we were about 9 in Enugu State, but I was victorious during the election. Okay. And I was even returned on the opposed again, because I am the one sponsoring the house, sponsoring the office of CB Network in Nigeria, because we don't have fund. So we still want government to assist us to rent places like this, so that sometimes people will not bother themselves to start going to where they cannot get vehicle to come in or to come out. Okay,
before we go into the organization and the project and everything, we are still talking on the disease itself. So before we go on that, let's just take a short break. We'll be right back.
Okay.
Every day, your health shapes your life, your strength, your choices, your future. Because knowledge is the first step towards well-being.
This is Health Matters, only on Aneke TV.
Join us on Arena, Aneke TV's premium current affairs program, where politics, development, and governance come live. Every Monday, Wednesday, and Friday, we host top professionals and thought leaders who speak their minds on issues shaping Nigeria and the world. It's inclusive, enriching, and absolutely captivating.
The roadmap is, let's have our environment secured so that investors can come.
If you don't know what economic security is, kidnapping will tell you what it is. You kidnapping, ransom.
Customers are going to get these meters, and like we said, it's at no cost.
There are things that dialogue can handle. But when you leave it, you want to use a kinetic approach alone. You cannot.
For discussions that promise insight and deliver truth, stay tuned, stay informed, and keep watching Arena, only on Aneke TV.
Welcome back. Today on Health Matters, we are discussing an important health issue, eradicating tuberculosis. Now, we are still on the issue of eradicating tuberculosis, and we just had a guest, Mr. Meniru Hamilton Chidozie, the State Program Officer, Civil Society for the Eradication of Tuberculosis in Nigeria. Welcome, sir.
You're welcome. Thank you.
We are glad to have you in the studio. As we were discussing on the aspect of poverty. Now, how does, from your own perspective, how do you think poverty affects the access to healthcare?
It's a serious challenge, poverty, healthcare. This is one of the things our project is trying to address. The project TB network is currently running in Nigeria, community-led monitoring. There are people who are poor in the community, people like us who are poor in the community, who cannot afford to access service at expensive places. That is, to God be the glory, we've been advocating, and it has been actualized. People like us that are in civil society organization, GRA, PHC, primary health centers, in all the political worlds. And the essence of the project PHC in all the political work is to make the health service affordable and accessible, so that people cannot travel far. The service will be there for you to access at zero sum, at minimal expenditure. Not just the service being there for you to access at zero sum. Knowing fully well that these services exist, you can pump in there to access those services at your will, at your wish, because staffs are there waiting for people to come and access those services. But the concern, the challenge we have is that people are not even aware we are poor. These things exist. We are not aware that these PHCs are where you can come to access services free of charge. So thank you for inviting us to talk on this health matter. Poverty remains a major challenge in health service delivery.
Okay, we often hear that TB is preventable and curable, yet many cases are still diagnosed quite late. So what barriers are preventing early detection and treatment?
Early detection, one of the key major challenges in TB management is knowledge, access to care. Like this thing you've just said, poverty. People see themselves, and stigma. Stigma is another issue that is affecting early detection. People see themselves that because I have TB, if I go for treatment, people will start saying, if because I'm coughing, because I have the sign, because we educate people on the major and minor signs of TB, whereby you cannot just conclude that those signs are TB until you go for medical checkup, medical examination. So those early detection, the challenge is a very strong one. Early detection, people don't see it as, should I even go for this thing? One of the things I attribute to it is our perception, Nigerian perception, to fear. To fear, meaning that this thing is not my for me. It is, which means I cannot have TB. Whereas TB is there, and people are having TB, they don't even come to access the services.
Okay, when you talk about symptoms, you know, you may just like I just did. Can you detect that I have TB?
You cannot.
That's why I asked, what are the symptoms apart from going to make checkups? Are there any
there are minor symptoms? One of them is that maybe coughing for I think for 2
weeks or more.
Constant coughing for 2 weeks. Persistent coughing, then your lungs will be paining you. These are the minor. So maybe when you are coughing and your lungs is paining you, start suspecting. Don't conclude that it's TB.
It's only testing that can determine whether it is TB
or not. And those testing services are free of charge when it comes to TB cases. The services, the drug distribution are free of charge. I like what you said before. TB is curable. It's treatable. It is not disease that you will see that because you have this infection, you cannot be cured.
Okay, let's talk about, you talked about stigma, right? How significant is the impact of stigma on TB controls efforts?
It is a very big challenge.
So how can it be addressed?
Being addressed is everybody should see it as a concern. I like what my coordinator rightly said before. If you are not infected, you are affected.
Directly or indirectly?
If you are not infected, you are affected. In the sense that those services, that person that you are saying, this person has TB. There is possibility that the person didn't know how he contracted this TB. One, there are things that the person would have been doing for you. The person will not be strong enough to even fetching or trying to make money to sustain the family. So at that level, that person is not enough to struggle to sustain the family, to make moves to sustain the family. The family starts doing what? Being deprived of their basic amenity, basic needs. So at that level, they are not affected. So you see, if you are not infected, you are affected.
Directly infected or indirectly infected.
Okay, now let's talk about community-led monitoring. How does this approach complement the work already being done by healthcare providers and government agencies? Before you answer that, let's take a look at the work that was just implemented, the project that was just implemented in Enugu State.
Deficiency syndrome and malaria. He attributed the situation to poverty, poor access to health care, long distances to facilities, and high treatment costs, noting that some patients travel over 30 kilometers for care. Chidozie explained that the ICLM project, supported by the Global Fund and implemented with the Institute of Human Virology Nigeria, is designed to strengthen health systems through community participation, improved monitoring, and accountability in service delivery.
The purpose of the grant is to address gaps in the health systems and infrastructure for sustainable, efficient, and effective health outcomes, as well as to ensure that communities and civil society organizations are integrated into the health care response, such that all contribute their quota to the achievement of positive results.
Also speaking, the state coordinator of tuberculosis
So, Chief, let's talk about this right now. How does this approach complement the work already being done by healthcare providers and government agencies in the fight against tuberculosis?
Just like what you have seen in the screen, it is something that it's not one man show. First of all, what we need to go about that is determination and collective will. If funders are coming and nobody is taking the thing to the grassroots level, it's not going to help us. So exactly what we are trying to do with community-led monitoring is that by the time we go to the place who cannot come out because of poverty, because of no transport or this, I think that's the only way to start changing the narrative, because people will always think that there's no need of going to access facility services. They don't even know that they have that thing near them. Or again, some of the facilities may be built in a place where people don't go because of transport money. So I think with what community-led monitoring is doing, the situation is going to have a difference, because already not sitting down in the office, but going to the place and see exactly what is happening in the community by using the available existing institutions.
Okay, so can we get your opinion based on this?
Yeah, community leading and monitoring to ensure that the health services are accessible and affordable. That is what CLM is. The summary of CLM. 4A and 1Q. 4A and 1Q. Making sure the health services are accessible, affordable. That is what CLM, the summary of what CLM is doing. And involving the people, letting the people know that, yes, government came and built this facility for you. It is your own. If you leave it, it will perish. If you leave it, government, who are the government? We are the government. We want to work, CLM wants to help the community to identify that we have so and so strengths to ensure that these health services are affordable, serves everyone within our reach. That's the major key thing that CLM is looking at. At the same time, not just making it to be affordable, there are some key things that CLM helps to identify or address. For instance, you come to the facility where people are, like the PAT where we are talking, or other facilities where people go to access, not just tuberculosis, health services in general. You identify that the staff strength is poor, insecurity, another thing. CLM helps to identify strengths from the communities
that need to be
strengths in the community, not just strength in those communities. Those strengths in the community, these are issues we identified in their community. If you help us to address this issue, don't wait for the government to come and do it alone. If you help us as a community to address these issues, health services will be improved in this community, in this location. If you help us to address that, for instance, also, there are some places where we work, the communities donated solar panel. Staffs don't work at night. There are no placenta pits. CLM we have to identify these are issues. Yes, government is supposed to do it, but if they are not doing it, as a community, you push should raise resources. There are indigent citizens within and outside the communities who has the willpower to donate something to the communities. There are also places where CLM has worked in Enugu. You will see people working. There are no doctors. Doctors don't come there routinely as supposed. The communities, CLM will have to do what? To them to amplify their voice, to know that you should demand this. This is a part of what CLM does. In the state, ensure that health services are affordable and accessible. There are also places where they don't have water. CLM will have to help the community to do what? These are your rights. You can do it. Don't just wait for the government to come and do this. The people, the government also, CLM also visit the staffs that are working at the facility. You notice that the staffs are there. People are not coming to access those services. Why? They are not informed. Lack of information. Fear of the unknown. Are you sure that if I go there, I will get those services I need? CLM helps to build confidence that these services that are there, the staff that are there, are more qualified than those patent medical dealers you went to patronize outside. Go there and gain such services. We build confidence in both ways. The service provider and also the service off-taker.
Let me come in there. There's another thing that is very, very important, following your questions. Formally, the government sometimes used to look at civil society organizations as auditors. We are not auditors. What we do as CSOs is to see where there is gap, go back to the government and put it to them. Your Excellency, you say you are going to give also another health facility before the end of the year. We have not done anything. Maybe he has forgotten. That's part of the work of the civil society organizations. So we go there to checkmate what is not done well, why it is not done well, what to be done, then recommendation on how to amend those things. And by so doing, we now say that the services will go very well.
So, sorry, you mentioned about the water supply and all that. These are practical, yes, these are practical terms that helps that have TB, yes, achievement, objective, and things that this community-led monitoring has done. Yes. Okay, now, how important are these interventions in strengthening healthcare delivery and improving TB outcomes?
Very, very, very important. Like, for instance, when there is no portable or available water supply, it affects service delivery. Service delivery in the sense that the person working in the health facility need to have water to wash, need to have water to clean the environment. To clean the environment. Yes. So if these things are not there, CLM help to identify it. Not just identifying it. If you identify a problem, you will solve it. If it's a problem that needs government intervention, you will solve it. If it's a problem that needs community intervention, you bring it to the community. It's not a one-off. CLM doesn't have a formula that the answer must come from here. You are solving a problem with what you see and providing solution with what you think is achievable. There's no one-off to solving problems. So the water is one of them, electricity is one of them.
Fencing of the compound,
the
security,
creation of services is also one of them.
Security is also
there are facilities that are there. People don't even come. CLM comes, when we come, we take the record, we see that this facility that is supposed to be having intake of 100 patients per day, inflow per day, you see them having 5. Could we just keep at, why is he having 5? It now boils to a question, why is it just 5 people that are coming to this facility per day? Why is it only on Thursday that people come here?
Recommendations.
So those things that we see, we have tools, as we are asking it, we are getting the answer from the community. And when we get the answer from the community, this issue comes from you, you also provide the answer. All of us will now put this together to solve it as a team. That's what CLM does.
Okay, since the implementation of this community-led monitoring, what can you see, Chief, what can you see as the most significant achievements being made? Since this implementation, since this project implementation, the most significant achievement. You know, he just mentioned a lot. He mentioned water supply and every other. What is the most significant? What is the main aim that you had in mind for implementing this community-led?
We have gotten a lot of gaps because of neglect, that is nonchalant attitude, and what again?
Ignorance.
Non-performance of the other thing we call patient charter and responsibilities, patient's rights and responsibilities. They don't know it, but community monitoring, community-led monitoring has made people in the town using the gatekeepers. You know the gatekeepers. Gatekeepers are, it may be Igwe, it may be President General, it may be, you know, that kind of, you cannot enter in a community without using those people. Though we do that when we do what we call needs assessment. Because you have to know, remember, this is just pilot too. This is just for 3 local governments, because we are going to domesticate it as time goes on, because it depends on the strength of the fund that is available. You understand? So this is why it is only Enugu North, Enugu South, and then for now. And we hope that as time goes on, we will domesticate it then and expand the program to other places. So patients' rights and responsibilities is one of the things that we solve that we are questioning, because if patient knows his or her rights, and the medical health workers know what they're supposed to do. Time has gone when you want to inject somebody, you don't tell the person the type of injection you want to give the person. The person supposed to say, doc, nurse, please, what type of medicine do you want to give? So you know your rights, you know what you have to do and when to do that. You know how to maintain the family. For example, if we discover that somebody has TB, it is another thing for us that we have to make sure that before we release that very person, we will be given what we call chemotherapy, to make sure that the other person who is taking care of that patient, maybe he has contacted the disease or not, will be protected while the main person is receiving treatment. You understand now? So by the time that patient knows his or her right, and the health worker knows his or her right, not that, are you coughing? Please sit down, go to the other place. You have even killed that very person, because other people in the hospital will no longer connive with the person. Oh, you are having TB. Oh, sorry. You understand that? So patient knows his right, her right. The health worker knows his or her right. Then the problem is solved. Okay,
let's talk about partnership. You know, partnership appears to be a key element of this initiative, bringing together government agencies, civil society organizations. Yes. So how important is collaboration in achieving this goal of eradicating tuberculosis?
One thing is that, for example, now, somebody may be contributing because he is a medical professional. Somebody may be contributing because he is an informant. Somebody may be contributing. You see why it is a collaborative something. The networking there is that you bring your own idea, I bring my own idea. We are only serving one Alhaji. You understand that kind of a thing? So it is not one man's show. I have told you before. So collaboration means, networking means using the already existing institution in a particular given situation to solve the problem we have.
So let me add first to what you said in terms of partnership. I think I should give kudos at this level to State Primary Healthcare Development Agency of Enugu State for their level of, for creating an enabling environment for CLM to thrive in Enugu State. It is a strong partnership. That partnership in the sense that CLM is thriving in Enugu State because of their strength. How do I mean by their strength? The PHs where CLM is being implemented is under their care, the care of State Primary Healthcare Development Agency. We are partnering with them. Some of the things that we profile or we do, we relate it with them. They see it as a need that these things we are doing for us matters a lot. We also cover, we do stakeholder mapping, stakeholder engagement. But there are a lot of challenges in CLM in Enugu State, which we believe we will talk about that when we get to that. So that partnership is very, very great. For instance, also, we partner with CLM is not just been looking at TB alone. We are looking at AT, and there is this we call ATM, is tuberculosis and malaria. There are state structures of these areas, we work with them. We also work with other networks that are in these areas. They bring initiative. They also bring ideas. When we go to the CLM, go to the field to get information, we all come to the drawing table. These are what we see in the field. We go what we call quarterly coordination meeting. At that quarterly coordination, or we come to your office. If we've identified an issue that your office is what will help us to solve the issue, we see us in your office. This is what we identify. And we believe you have the strength to address this issue. Because we do what we call stakeholder mapping. Those stakeholders, in the level of that stakeholder mapping, we identify stakeholders that are relevant to what we have identified. We move to that stakeholder. The CLM has a project, a process that maybe you come to and you have an issue. People are doing this. The issue has been persistent, have been discovered. For instance, in Enugu, one of the key major issues is inadequate staff. Manpower. That is lack of manpower. And to God be the glory, the agency involved responsible for this action, State Primary Healthcare, is already working on it. I believe they are trying to engage more people to address it. But we did not just stop there. That if there are no staff, CLM says if the staffs are not adequate, yes. But what do we do to make the health services affordable, to let people still see where to access health service? We move with the community people. Why not engage CVs? There are some things, and not just engaging CVs.
Let's know the meaning of CV.
Community, it's community volunteers. Engage CVs that will help to augment what you are doing. And those CVs that you are engaging, let it be there are some remuneration that are allocated. CLM is not the people. We motivate or help the community to amplify that these are what we can do.
That's right.
On one table, if you do this, do that. Because there's no one, like as I said before, there is no one formula in addressing issue. Once you are faced with the issue, the answer comes from the issue. That's how CLM approach works. So partnership is key from the community, from the government angle, from the civil society organization. We partner greatly to achieve CLM aim.
Okay.
Like we are partnering with you as media.
Yeah.
We cannot do this thing at the kitchen. You are the mouth, our voice, so let other people know that this is what we are doing.
Before we conclude, if there is one key message you would like our viewers to take away from today's discussion on eradicating tuberculosis, what would that be?
One key thing I want to drop to our people is that TB is there. See yourself that you are an advocate. Anywhere you see yourself, talk about it. Stop stigma. And at the same time, from the government angle, support CLM process. CLM is being implemented in 3 LGAs in Enugu State. Our coverage is very, very poor. Enugu State have 17 LGA. CLM have 3 LGA coverage.
For a start.
Other LGAs, what happens to them? CLM is being funded by Global Fund through IHVN. So at this junction, let the state see that CLM should be expanded in the state. So that's my key message.
So before I get your opinion on this same question, how long has this been on?
CLM started in Nigeria last year, October.
Just that there is no much awareness.
We are doing the awareness in our own capacity. Not just that there is no much awareness. The coverage is low. We have 17 LGA. CLM is being implemented. 3. You see, the coverage makes it people are not necessarily aware. So that is why we are using media to amplify.
Together. All hands must be on deck to get this situation arrested, to improve on the stigma. Social stigma is one of our problems. Okay. So by the time the government can buy in, the community can buy in, you say that the matter is solved. Hence, it is treatable, it is free, and in short, there's nothing to stop somebody from going to the nearest facility to access the drugs. We don't want drugs to be expiring any longer, because part of our job is to let them know that this is here and that they can access it free of charge.
Okay, thank you very much to our guest for those insightful and valuable information based on this subject. We really appreciate. And thank you to our viewers for staying with us to the end of today's program. As a reminder, the fight against tuberculosis remains a collective effort. Through increased awareness, early diagnosis, proper treatment, community participation, and stronger healthcare systems, the goal of eliminating tuberculosis becomes more achievable. That brings us to the end of today's program. I am Sharon Uche. Thank you for watching Health Matters on Aneke TV. See you next time.